can see
Audio recording for this meeting has begun.
As you can see from this image, the colon has 4 sections. So the ascending colon begins at the small intestine. The transverse colon crosses the body from the left to the right, and the descending colon descends on the left side. The final part of the colon is the sigmoid colon, which is named for its S shape, and it is the final part of the colon that joins the rectum. So colorectal cancer usually starts as a non-cancerous growth called a polyp, and that can develop in the inner lining of the colon or the rectum, and it usually grows pretty slowly over 10 to 20 years. About a third to a half of all individuals will eventually develop one or more polyps or adenomas, so they are pretty common. And although all adenomas have the potential to become cancerous, fewer than 10% are estimated to progress to invasive cancer. But the likelihood of them becoming cancerous increases as they get larger, which is important, an important reason to receive screening. So there are a couple types of polyps, including mushroom-shaped polyps that attach to the colon by a thin stalk, and these are called pedunculated polyps. And then there's also sessile or flat polyps that have a much broader base and may be flat or depressed, which can make them a little bit harder to detect. Genetic syndromes such as familial adenomatous polyposis, or FAP, which is much easier to say, can produce hundreds of adenomas and greatly increases your chances of colorectal cancer. And you can see that in the bottom left-hand corner of that image, all the polyps that come with that genetic syndrome. So cancer arising from the inner lining of the colorectum is called adenocarcinoma typically. So adenocarcinoma accounts for approximately 96% of all colorectal cancers. And so once cancer forms inside the colon, it can grow into the outer wall of the colon or the rectum, and then it does have the potential for metastasis to lymph nodes and can be spread to other organs, including the liver or the lungs. So quickly, just to touch on some symptoms of colorectal cancer that are fairly well known. Symptoms could include bleeding, changes in bowel habits, unintentional weight loss, and then cramping or discomfort in the lower abdomen. Oh. Jan, do we know what's going on with the, does everybody else's look wonky like mine does?
Yes.
Earlier, we could go into the Chrome and type in that address, and then we could get it.
All right, so some risk factors for colon cancer. So age is the biggest risk factor for colon cancer. As you get older, your risk for colon cancer dramatically increases, and most colon cancers are diagnosed after the age of 50. It should be noted, though, that although most colorectal cancers are diagnosed after the age of 50, there has been a substantial increase in colorectal cancers for people under 50 recently, with the majority of these people being diagnosed in their 40s. And there is ongoing research to determine why this is. So gender also plays a role in colorectal cancer risk. So men have a 30% higher incidence rate and a 40% higher mortality rate, although, as I previously mentioned, colorectal cancer is common in both men and women. So this difference is also not well understood, but is likely due to exposures to risk factors and the sex hormones, and then the interaction of these factors. The slides are coming out. The other risk factor is race. So African Americans have the highest incidence and mortality of all groups in the U.S., and then Pacific Islanders and Asians have the lowest. And this racial disparity can be attributed to less screening and more distant disease at diagnosis. Dan, should we try and upload these again if they're all going to have...
If you try to connect.
Oh, wait.
Okay, so those look a
Do
little
they
bit
look better now? Okay, but
so-
we can do that. I'm just having Kathy look at it. I'm sorry, I tried to answer before, but I forgot I was on mute. So,
Okay, it looks like the
So-
following ones get a little bit better.
okay. All right, well, let's go with that for now, and then we'll because I think we'd have to stop the presentation to reload them.
Okay, and we will send out the slides to everyone so you can see what they actually look like well formatted. So I apologize for that, everybody.
Well, I'm sorry, too. That's a little disconcerting. Thank you.
Yeah. Other risk factors that contribute to colorectal cancer include behavioral risk factors such as alcohol consumption, obesity, physical inactivity, red meat consumption, and processed meat consumption, and then smoking. So compared to non-drinkers or occasional drinkers, people who have a lifetime average of 2 to 3 alcoholic drinks per day have about a 20% higher risk of colorectal cancer. And that increases to 40% for people that have more than 3 drinks per day. And this association is higher in men than women. So related to physical inactivity, physically active people have a 25% lower risk of developing tumors than the least active people. And then there's been some recent information kind of around the processed meat and red meat consumption. So food-specific items in cancer occurrence are pretty difficult to study, but there are studies that show that both red meat consumption and processed meat consumption increase the risk of both colon and rectal cancers. The reason for this remains unclear, but it may be related to the carcinogens that are formed during high-temperature cooking, curing, and smoking of meat. And then there's also familial risk factors for colorectal cancer, as I mentioned previously. So up to 30% of colorectal cancer patients have a family history of colorectal cancer, and then about 5% of colorectal cancers are due to inherited genetic abnormalities such as Lynch syndrome or familial adenomatous polyposis. All right, this one looks okay. So here's kind of a snapshot of colorectal cancers in Wyoming. So in 2015, which is the most recent data that we have, 196 invasive cases of colorectal cancer were diagnosed in Wyoming. And then there were also 90 deaths from colorectal cancer. And you can see this broken out between males and females. So the incidence rates for colorectal cancer in males, females, and the total population are all below that of the national rates. And then the mortality rates in males is lower, and the total rate is essentially equal to the national rate. So a little bit of a comparison there for the state versus the whole country. So incidence rates in Wyoming continue to decrease as the national trend has really leveled off over time. One interesting thing to note, though, is the percentage of colorectal cancers diagnosed at the local stage, meaning that they haven't metastasized, decreased in 2015 to 44% from 36% in 2014. And then the regional stage, meaning that the cancer has traveled, increased to 36% from 33% in 2014. So here's the colorectal cancer screening data for Wyoming. So 65.2% of Wyoming adults report ever having a colonoscopy. And then you can see on the slides that this is broken out by age and gender also. In addition, beyond just colonoscopy as a screening modality, 61.1% of Wyoming adults have completed a screening test that meets United States Preventive Services Task Force recommendations. This makes Wyoming 47th in the country in colorectal cancer screening. So this graph shows the screening trends for the past about 20 years. So as you can see from the graph, we have been increasing colorectal cancer screening, but we still do lag behind the national average of 74.4% and are significantly behind the national goal of 80% screening by 2018. So knowing that we need to increase colorectal cancer screening rates in Wyoming, I'm now going to go over the current screening recommendations and the colorectal cancer screening tests. So before I do that, I do have a question. So we're not going to take a poll or anything, but I'll just give you guys a minute to think about what is the best test for colorectal cancer screening. And it's a little bit of a trick question. So the best test for colorectal cancer screening is the test that gets completed. I'm sure that many of you had colonoscopy come to mind, and in fact, many primary care providers will only recommend a colonoscopy. But studies have shown that patient preferences are important, and when given the option of multiple screening tests, patients are more likely to complete the test that they choose to do. In one study, when patients were given the option between a stool test and a colonoscopy, a third to a half of patients chose the stool tests. And we'll talk a little bit more about stool tests in a second. So here are the current United States Preventative Task Force screening recommendations. So the USPSTF recommends colorectal cancer screening beginning at 50 years of age and continuing until age 75, with the recommended tests including high sensitivity guaiac-based FOBT or FIT test every year. So these are two types of stool tests. A colonoscopy every 10 years, stool DNA testing every 3 years, CT colonography every 5 years, or flexible sigmoidoscopy every 5 years, or the option of a flexible sigmoidoscopy every 10 years plus a FIT every year.
Exactly.
So now to dive a little bit more into stool tests. So the high sensitivity guaiac test is a recommended stool test, and this includes brands like Hemoccult Sensa. So this test detects blood in the stool, but it does only detect blood. It's not specific. So if you have a rare steak or a bloody nose that you swallow some of the blood, this can also cause positive results. This test is commonly compared to the much less sensitive stool tests from many years ago that are no longer recommended. The other stool test is the fecal immunochemical test, or a FIT. And so this test is sensitive specifically for human blood and the globin molecule, which makes it more sensitive to blood in the lower GI tract. So studies suggest that lives saved through using a high-quality stool-based screening program are nearly as effective as using a high-quality colonoscopy-based screening program when there's strict adherence to the program and needed follow-up occurs at recommended intervals over the lifetime. So on average, less than 10% of stool tests will be positive, and about 1 in 20 colonoscopies from those positive tests will actually be cancer. A couple things to note is that these tests should be done in compliance with the instructions. So digital rectal exam stool specimens are not an adequate way to complete a stool test or to test for colorectal cancer. In one study, 19 out of 21 cancers were missed by using a digital rectal exam. And per the screening recommendations from the USPSTF, only average risk patients should be using stool tests. Dan, do you want me to try and upload them again?
Or you can share your screen instead of doing it through the webinar if you think that, yeah, because this is unreadable.
Okay. Let me try and upload them again and see if that helps.
Okay.
Sorry, everyone.
Allie, while we're waiting, if you want to take some questions, or if anybody has questions they want to type into the chat box, please feel free to do that. It's up to you, Allie, whether you answer them now or later.
Yeah, I'm open to answering questions right now while we hopefully quickly get this back up.
Yeah.
So the way we do ours with those little kits. We have the FIT test. And that's a good one too. Yeah, that's still one of
That looks better, Allie.
All right, so this will be a little bit clunkier here in a PDF, but hopefully you guys can read all of the slides.
That's much better. Yeah.
Okay, so here is kind of the pros and cons of both of the stool tests that I mentioned. So, of course, one of the big pros of a stool test is that there's no bowel prep, the sampling can be done at home, and they're pretty inexpensive to administer. One additional pro of the FIT test is that there is no pre-test diet changes. Like I mentioned, that steak doesn't matter because it is sensitive for the human blood. Cons of the tests, they do need to be repeated every year, and there is a chance for false positive results. And then one thing that is really important to remember is that if a stool test is found to be positive, a colonoscopy is necessary. So if there is a patient that doesn't want to do a colonoscopy, they need to understand that that is the follow-up, but the test is positive. And then one other thing, so under the Affordable Care Act, A and B recommendations from the USPSTF should be covered without cost or copay. However, if follow-up screening, including a colonoscopy, is necessary with a positive FIT test, there may be cost sharing depending on how it's billed by the clinic and the patient's insurance coverage. So that's also another thing to think about. And the American Cancer Society does have a great resource on specific stool tests that are recommended and that have been shown to have high sensitivity and specificity.
Allie?
Yeah.
Can I just quickly ask everyone to mute their lines? There's quite a bit of background noise right now, and it'll help everybody hear if we can all be on mute. Thank you.
So there is reimbursement available for stool tests for clinics that are interested in starting their own FIT program. So here are the 2018 rates for FITs, and then we do have that compared to the FOBTs. So if you do start a FIT program in your clinic and you do have a high return rate with the kits, it is possible for your clinics to generate income as the reimbursement is much higher for FITs than it has been previously with the FOBTs. And then, of course, test costs and lab processing fees can vary by test type. So colonoscopy, this is probably the most well-known colorectal cancer screening test. So for this test, the doctor looks at the entire length of the colon and the rectum with the colonoscope, and that is a thin, flexible, lighted tube with a small video camera at the end. So here are the pros and cons of the colonoscopy. So you do have the opportunity to look at the entire colon. They do only need to be done every 10 years. And another pro is that if polyps are found, they can be removed and biopsied during the colonoscopy procedure. Cons of the procedure: the full bowel prep is required. The patient would need to be sedated and then have someone that could drive them home. And typically people have to miss a day of work for the procedure. And then also it's just a little bit more of a high-risk procedure. So there is the risk of bleeding, bowel tears, and infection that some of the other tests don't have. So here are a couple of other recommended screening tests that are a little bit newer technology. So the stool DNA test uses a stool sample, and then the colon cells are spun down, and then the DNA is actually looked at for any abnormal sections or mutations. The only brand that currently offers this test is Cologuard, and they also do a FIT test along with the DNA test, so you get a little bit of a 2-for-1 there. But this is a newer test, and so it is kind of just coming out. The other test is a CT colonography or a virtual colonoscopy. So this test does a CT of the whole colon and rectum. So here are kind of the pros and cons of these tests. So with the stool DNA, similar to the other stool test, is there's not any bowel prep required, and there's not any pre-test diet changes that are needed, and that it can be done in the home. And then some of the cons of it are similar to the other stool test, that there could be false positives. This test doesn't need to be completed every 3 years currently. It is a newer test, so they're continuing to study what exactly that frequency should be. And then you do have to complete a colonoscopy if that test is abnormal. This test is covered by Medicare, but there could be some reimbursement issues with private insurance, just with it being a newer test. With the CT colonography, so this test is pretty quick and simple. Like I mentioned, it's just a CAT scan. It does need to be completed every 5 years. Cons of the test: you are required to do the full bowel prep. So if you have patients that the prep is really the thing that makes them not want to do a colonoscopy, if they think that this test sounds like a good option, they do still have to do the full bowel prep. And then a colonoscopy is still needed with this test too if there are any abnormal findings. And then also there could be insurance issues with coverage. So there are a substantial amount of resources available through the American Cancer Society and the National Colorectal Cancer Roundtable. I'm going to provide some highlights of a few of these materials. There are a lot of links included within these slides, so whenever you guys receive the slides via email in the next couple of days, you can use the links to explore the toolkits and the materials a little bit further. Like I said, I am just going to kind of do the highlights of a few of these. There are full hour-long webinars on many of them on the National Colorectal Cancer Table website. So if you're interested in that, you can certainly visit that website too. So there are a couple of toolkits specifically related to increasing colorectal cancer screening in your clinic. So this one is for primary care providers, and it talks about the importance of provider recommendation, knowing clinic and provider screening rates, So you can determine who your high-performing providers in your clinic are, and if you already have a provider champion within your clinic, setting goals and expectations, understanding the screening options, so kind of what I just went over, and making sure that all of your staff is aware of that, and then understanding insurance coverage. So understanding that you might have clients that if they have a positive FIT, their insurance might not cover their follow-up colonoscopy fully, or if you're talking about some of the newer screening modalities, that insurance coverage may not cover that. The other toolkit is specifically for health centers and FQHCs, and this toolkit really talks about getting your plan together. So making a plan, assembling your team, identifying that provider champion, and then figuring out what you're going to do to get patients screened. Are you going to start a FIT program? Are you going to work with providers in your area to do some colonoscopies for your patients at no cost for those folks that don't have insurance, and then coordinating care across the continuum. So what happens if patients need follow-up screening or treatment and don't have insurance? So along with the resources from the National Colorectal Cancer Roundtable and the American Cancer Society, the Community Preventative Services Task Force, or the Community Guide, also recommends using multi-component interventions to increase colorectal cancer screening. So they have separated them into increasing community demand, increasing community access, and then interventions that are specifically targeted at providers. So to increase community demand, you can do client reminders, so reminding clients whenever they're due for screening, or reminding them that they need to complete their screening test, providing client incentives, so providing an incentive to clients that complete their screening. Small media, which could include brochures or flyers or handouts. Mass media, so radio, television, those type of ads. Group education, so scheduling group education with your patients or community, and then one-on-one education with patients that could happen directly in the clinic. So interventions to increase community access include reducing structural barriers. So this could include things like assisting with appointment scheduling, having alternative hours for your office, or alternative screening sites that is easy for people to reach, addressing transportation barriers or language barriers, and then offering child care. And then reducing client out-of-pocket costs. So this could include handing out FIT kits for free, or providing other services that can decrease the cost to patients. And then interventions specifically targeted at providers, so provider assessment and feedback. So similarly to what I mentioned in some of the toolkits, is really seeing where your providers are at with their screening rates, and then determining what steps can be made to increase them. Doing provider incentives, so incentivizing or creating a competition among the providers in your clinic to see who can have the highest screening rate. And then provider reminders, so that could be implementing changes into your electronic health record, or flagging patients over 50 to make sure that providers are reminded to talk to them about colorectal cancer screening. And then one specific evidence-based program that I wanted to mention is the FIT program. So the FIT program uses increases colorectal cancer screening rates by providing a FIT test to eligible patients when they receive their annual flu shot. So FIT tests should be done annually, and flu shots should be done annually. So this creates an opportunity to reach people who are due for colorectal cancer screening that might not come into your office otherwise. The FIT website offers program planning and implementation materials, including staff training, workflows, log sheets, and then sample reminder letters and phone scripts. The website is really comprehensive. It has education materials and posters and flyers and videos. in multiple languages, so if that is a need of your clinic. And then there's also materials that can kind of help your clinic team get set up for the program. And then one of the most successful tools that or maybe I shouldn't say successful, most utilized tools that the National Colorectal Cancer Roundtable has created is the Communications Guidebook. So the guidebook uses tested messages to increase screening, and the information in the guidebook includes how to reach the unscreened, addressing barriers to screening, motivating the unscreened, and then tools to really reach targeted populations. And within this guidebook, there are 5 specific populations that they address. So the newly insured, for folks that might have insurance for the first time due to the ACA requirements, folks that are financially challenged, insured procrastinators or rationalizers, including the people that are unworried well, that are like, I'm fine, I don't need the screening. And then there are specific messages for African Americans and Hispanics, and that does include information in Spanish. And then this just breaks down within the guidebook some messages that you can find. So all of these are ready-made for you to really tailor to your clinic or your population. So all of these are linked in these slides, so you can go directly to them to see some examples here. And then the other communications-related toolkit I wanted to mention is the Colorectal Cancer Awareness Month Social Media Toolkit. So this was created by the George Washington Cancer Center and includes ready-made social media messages, including Facebook and Twitter. It even has a calendar for what you should post on what day, and is a really easy thing to do if you're interested in promoting colorectal cancer awareness on social media. So beyond working in your clinic and messaging, there are also strategies to increase colorectal cancer screening as an employer. So there's another toolkit. So the National Colorectal Cancer Roundtable created the Employers Toolkit, which talks about adopting corporate goals, educating employees, and then engaging insurance providers to make sure that screening coverage is comprehensive, or working to reduce premiums for employees who have received recommended cancer screenings. So a lot of great tools within the working with the insurance providers. The other thing that this toolkit talks about is creating a screening-friendly environment. So that could be providing days off for staff to receive screenings without taking any of their accrued leave, or really just making it a culture that everyone receives their cancer screenings. So far, most of what we have discussed includes screening insured populations. So now let's transition to a couple of programs and resources that are available for uninsured or underinsured populations, specifically in Wyoming. So the Integrated Cancer Services Program, which is the program that I work for, so we're at the Wyoming Department of Health, and we reimburse participating healthcare providers for breast, colorectal, and cervical cancer screening services for clients that are enrolled in our program. Some other things that our program does: we implement the Wyoming Cancer Plan, we work with the Wyoming Cancer Coalition, and then we manage the Wyoming Radon Program and the Wyoming Cancer Resource Services contracts that are throughout the state. So specifically, a little bit about the colorectal cancer screening program. So the colorectal cancer screening component is funded through tobacco settlement funds set aside by the Wyoming legislature. So this program reimburses healthcare providers that are enrolled in the program for colorectal cancer screening tests, including colonoscopies for enrolled clients. And one thing to note here is that if a client's insurance doesn't cover the colonoscopy following a positive FIT, they may be eligible for our colorectal cancer screening program. And so here are the eligibility requirements for our colorectal cancer screening program. So very similar to some of our other screening programs also. So 50 years of age or older, a gross household income at or below 250% of the federal poverty level, uninsured or underinsured, so it is possible for folks to have insurance and be enrolled in our program, and then they must have been a Wyoming resident for at least a year. So this is the website that has more information about our programs and the applications. And then the other colorectal cancer screening component of our program is our FIT Kit program. So the FIT Kit program increases availability of colorectal cancer screening through stool tests to folks across Wyoming, specifically those who are uninsured or underinsured or that live in frontier communities and don't have access to other screening services. And this program is administered by our program through support from the American Cancer Society. So the FIT program has become very popular with many of you on the phone participating. So we should be receiving our next year of funding soon, and we have made a few changes to the program to make sure that we are really reaching our intended audience. So if you're currently participating in the program, you will be receiving a revised program manual soon. And if you're interested in participating, after I go through these next few slides, you can contact us and we can get you involved. So who can partner with the program to distribute FIT kits? So our program partners with providers, clinics, and organizations across the state, specifically those that really work with that uninsured, underinsured, or hard-to-reach population that has limited access to other colorectal cancer screening services. And then we partner with them to directly distribute the tests to the clients. So the FIT kits that are distributed through the program are made available for free to the clients, and therefore the clinics that are participating with us should not be receiving reimbursement for them or charging the clients. So who should be receiving FIT kits through the program? So our guidelines align very closely with the recommendations from the USPSTF, along with a few Wyoming-specific ones. So we do require clients to be a Wyoming resident, be age 50 to 75, have not had a colonoscopy in the past 10 years or a stool test in the past year, have no history of bleeding, ulcers, or hemorrhoids, or no current symptoms, and then be a person of average risk, as I mentioned earlier. So that means that they don't have a family history or a personal history of colorectal cancer. And then clients should also be uninsured or underinsured or have a low likelihood to screen for colorectal cancer through any other method. And then, again, kind of being geographically isolated with limited access to other screening services. So this program is definitely a partnership. So the partners within the program are responsible for providing education to the client, including information about all of the colorectal cancer screening options, distributing the kit with instructions to the patient to make sure that it is completed correctly, and then following up with the patient if the test isn't completed within 3 months. And then in addition to that, we are requiring our partners to follow up on any abnormal results and set up that next step in screening, so that colonoscopy for those patients. So the Integrated Cancer Services Program covers all the costs of the programs, including the kit, the postage, and the lab fees. And then our program will also send out letters to clients if their results are normal. So in summary, screening can prevent colorectal cancer and reduce colorectal cancer mortality. There are multiple types of screening tests, and providing options to patients is really important. There are lots of resources available to increase screenings in clinics. So like I said, there are links within these slides, but also if you just Google National Colorectal Cancer Roundtable, you will find an overwhelming amount of great resources that they have put together. And then that does include some specific messaging for communities that can be used by organizations that aren't in the clinics and the media. And that we do have some pretty great programs available in our state for uninsured or underinsured clients that we would really like for more people to take advantage of. So if you are interested in learning more about our state colorectal cancer screening program or the FIT Kit program, you can contact me. There's my contact information. And then there's our website and our 1-800 number that can also provide information also. So that is all I have. And whenever I switched this to my PDF, I couldn't see if there was any questions.
So we do have one question. Please clarify the statistic 65.2%. Does that include FIT kits or only colonoscopies?
So 65.2 only includes colonoscopy or sigmoidoscopy.
Okay. And anybody that has questions now, feel free to unmute your lines and ask them or put them into the chat box, whichever you prefer. Great job, Allie. Thank you for going to your computer. The slides are much more readable. And
yeah, I'm sorry, I don't really know what happened there.
Well, I don't either, and I'm novice at this. So, but great job. You did that in just the right time, and it looks so. The questioner was Val Walsh-Haynes, and she thanked you for the information, and I think we have another question coming. Oh, just another thank you for you. So. Okay, Jamie has a question. She's raised her hand. Jamie?
Trying to clear. Hi, Allie. Could you email us that PowerPoint so I could send it along out to my HM team?
Yes.
Thank you. And the resources and whatnot that go with it?
Yep. And if you guys have any questions once you get the email, you can feel free to email me, and I can send you more resources. If you're looking where to find something specific, I'm happy to help forward that information on.
Great.
Wonderful. That was a nice presentation. Thank you.
Yeah, thank you.
Well, in the little bit of time we have remaining, we actually have, you know, a few more minutes if folks have questions. Otherwise, I want to say that the Wyoming Primary Care Association has recorded this, and we will be making the recording available on our website, and we'll send that out at the same time or try to as the slides go out and the survey goes out. So we'll make sure that you have everything that you need along with a possible recording on our website so that you can click back in if you'd like to watch it again or send some of your other staff to it.
Yeah, she was going to go back on it. Yeah. So if you don't get it, I get it. You should.
Allie, it looks like we've got another person typing a question. Will we automatically receive the PowerPoint presentation?
Yes. If you're registered for the webinar, we will send the slides out to everyone that has registered.
Great. Okay. So I think we've got another person typing, and I think that'll probably be the last, unless people have questions. I can raise their hand. Stephanie Schneider said, thank you. I will share these with all of our doctors here at the UW Family Medicine Group. So that's great news. This will get the information out there, Allie, and we really appreciate your time today. I want to again thank the American Cancer Society, as well as the Integrated Cancer Services Program at the Wyoming Department of Health. They're great partners with us, and we really appreciate everyone's work. At this time then, I think, unless, Allie, you have some final thoughts, we'll go ahead and sign off.
Yeah, Jan, the only other thing that I would add is if anybody is interested in working more closely with us to increase screening rates in their clinic or within their organization, so Stephanie, if there's anything we can do to kind of help or move anything along at UW Family Medicine, certainly let us know. That's definitely one thing that our program is really interested in doing and would be happy to work closely with any clinics that want to do some work with us.
Excellent. Well, thank you, everyone. Be sure and make sure that you've got Allie's contact information. You can reach us here at the Primary Care Association and, of course, the American Cancer Society. Let us know if you have any questions going forward, and otherwise, sign off. Thank you.
Thank you, everyone.